TopMedTalk.
This is part 2 of a 2-part piece. Dr. Paul Wischmeyer, Professor of Anesthesiology and Surgery at Duke University.
Then the question comes, well, maybe with ERAS, we don't need immunonutrition anymore. Maybe ERAS has reduced infections, so it doesn't matter. Well, this is the Spanish ERAS group, the Moya group, and they showed in a large study of well-done ERAS studied patients. This is a well-done study from the Spanish ERAS group. They looked at 264 colorectal patients receiving ERAS, and they show that immunonutrition still significantly reduced complications and wound infections in patients versus routine oral nutrition supplements. So there's still a strong role for immunonutrition in the ERAS protocol. So do I need to tell you any more? This works, and we should all be doing it. But the real question is, do we do it? Unfortunately, our surveys show that less than 1% of US patients at least are receiving these immunonutrition formulas, even though the data clearly says they should be. So we must be better. We must be getting these. We must find ways to get these to our patients. So what about Michelle again? She's malnourished. She's having an elective surgery. Should we cancel her surgery? Give pre-op nutrition for 1 to 4 weeks like our guidelines suggest. Unfortunately, despite evidence to say to do this, this didn't happen. She didn't get preoperative ONS, and she went to surgery. So the morning of surgery, should she get a carb load drink? Of course, pre-op carb loading has gotten a lot of attention lately. It's a key part of the ERAS guidelines, that and minimizing MPO periods. And we know that minimizing MPO periods is essential. We shouldn't have patients MPO after midnight and for hours and hours. They should only be MPO up for clears up to 2 hours before surgery. And this is part of our recommendation and many others as well. And then we recommend a complex carbohydrate load be given 2 hours or more before surgery to reduce surgical stress and insulin resistance in our patients. And there's strong data for this. This is the Cochrane review of preoperative carb loading for our patients in major abdominal surgery. 10 trials, over 800 patients, reduced length of stay, this few dollars, $3, $4, 1 3-pound drink, reduced length of stay 1.5 days. So this is a dramatic effect from a simple, safe intervention. But it has to be done right to have it work optimally. And how do we do that? And it's 50 grams of a complex carbohydrate, perhaps 100 grams the evening before, is like carb loading for a marathon or any other race. And it needs to be a 12% carbohydrate drink, low in osmolality to ensure gastric emptying. So what about sports drinks? I get questions. What about Gatorade? What about orange juice? They do not work the same. They are not as safe, and I can't assure you they're safe at all. They contain 6 to 7% carbohydrate as a simple sugar and almost no maltodextran. They have a high osmolality. Both these simple sugars and this high osmolality delay the gastric emptying of these sports drinks, potentially increasing your risk for aspiration. There's no literature to support their use that I have seen yet. So if you were to have an aspiration event, it'd be very difficult to defend yourself when there's vast literature for the complex carbohydrate drinks being safe and emptying the stomach well. We know these empty the stomach slower. For best results, this should be drunken quickly. The carb load needs to be taken over 5 minutes, not 2 hours. Otherwise, it doesn't work very well. It doesn't do what it needs to do. This was studied by Franco Carli. Healthy patients taking 50 grams of glucose over 5 minutes versus sipping it over a few hours had significantly large differences in insulin response. And so the insulin response will not achieve what we want for our preoperative patients if these are not taken over a few minutes. So you got to educate your patients correctly. They need to drink them quickly. And then again, maltodextran produces faster gastric emptying, which is why it's been what's been studied in all of the studies. And this is likely related to the osmolality, which is much better than the simple sugars. Again, avoid the juices, avoid the sports drinks. Then the question is, maybe we should put some amino acids, some arginine, some citrulline, or some other amino acid in it, which might make some sense to help the protein synthesis and perhaps the immunonutrient effects. But the reality is amino acids, especially arginine and citrulline, delay gastric emptying. They produce nitric oxide, they slow the stomach, they increase your risk for aspiration. I wouldn't use products that have arginine or citrulline in them. There's just lack of safety data, and the physiology doesn't speak favorably for these. So again, we have strong data for this inexpensive, safe intervention, but do we do it? Many centers, I can tell you, in the US do not. And so this patient, Michelle, didn't get it either. So she goes to surgery. Now she's post-op. When should she start eating? When should she start taking an oral diet? Well, we recommend a high-protein diet be initiated on the day of surgery, right out of the recovery room. And traditional clear liquids and full liquid diet should not be used except for the oral nutrition supplements with protein in them. This idea of broth and juice and things like that, those are not healthy. Those are just salt and sugar and are not healthy for your patient. So the question always comes post-op day one, no bowel sounds. Should they be fed? Well, do bowel sounds matter? Well, even our famous TV doctors know bowel sounds have no relevance to feeding or readiness for feeding. There's been many studies going back 30, 40, 50 years that show bowel sounds don't equal gut function. And the return of bowel function is the same in an open versus a laparoscopic procedure. And in fact, the surgeons have almost nothing to do with the ileus time. It's all about the time we take before surgery and after surgery to feed them efficiently and do the good ERAS practices. So again, this has been studied. This was a Cochrane review of studies that fed patients right out of surgery in the first day versus waiting for bowel sounds a few days later. There weren't differences in pneumonia. The patients fed early didn't vomit more. They didn't dehisce their wounds or anastomoses more. But what they did do was live more. Getting fed in the recovery room early in this study of almost 1,000 GI surgery patients reduced death 60%. Even if it's 6%, this is millions of lives saved. This is a major intervention that we all should be doing, is feeding our patients early. It changes outcomes. This is an outstanding study by Ali Lundquist's group, 900 surgical oncology patients who were found to have more than 70% compliance with ERAS versus those that didn't. 42% reduction in a 5-year mortality. So those of you who are practicing good ERAS, you are saving lives years later. What you do around the week of surgery or even the day of surgery changes outcomes years later for our patients, this says. And the two big factors that predicted improved outcomes were oral intake on post-op day one as a major indicator, predictor of 5-year survival, along with good fluid management. Those were the two big factors, fluid management and oral intake on day one. So this is something you can do now for your patients. Again, do I need to tell you any more? This works. We should just be doing it. So unfortunately, most patients are in PO for more than 3 days post-operatively. In fact, we know we feed surgery patients the poorest. It takes the longest to start nutrition versus other hospitalized patients. They get the least amount of calories over time. And cardiac and GI surgery patients who are at the highest risk of malnutrition are fed the poorest. We published this a few years ago. So again, we must be better. So I think a key way to start being better is it's always more important to get to protein goal first than total calorie goal. So work towards that. There's a nice study in a very high impact clinical nutrition journal from a few years ago that shows in colorectal surgery, getting in even just about 20 or 25 grams more protein per day after the colorectal surgery reduces length of stay by 4 days. So just getting in more protein, getting in 60% of goal over the first 3 days of a surgical intervention in the colorectal surgery reduces length of stay 4 days. So if we promote protein provision, good nutrition will follow. Sadly, we all underfeed protein, and our patients can't eat enough when they start eating. They don't feel like eating. Their appetite has been lost. They won't get enough protein in on their own. And so we know patients don't eat enough after surgery. This is the average intake they have, which is far insufficient for what they need. So this was one of the strongest recommendations the committee made. We recommend post-operative oral nutrition supplements, high-protein oral nutrition supplements, those little drinks you can drink to meet our patients' protein and calorie needs in all patients having major surgery, not just malnourished patients, all of us. So these are key, and perhaps even in our most weak and most debilitated patients, even an anabolic agent may be helpful, but oral nutrition supplements are essential. We have a lot of data for this. We know that in major meta-analyses, oral nutrition supplements reduce hospital mortality when they're used. They reduce hospital complications significantly. We have a large study that was done recently in almost 1.5 million patients in a major healthcare database. We found 724,000 patients who've gotten ONS, at least they've gotten written for it. We don't know if they drank it even. And those patients who got it versus the 700,000 that didn't had a reduced length of stay by 20%. And every dollar spent on those little drinks saved $50 in hospital costs. And now we finally have a large randomized trial of these high-protein H&B. H&B is an anabolic nutrient, H&B containing ONS. This was 78 centers, 650 patients, reduced mortality for the 3 months after hospitalization discharge by half. So again, 90-day post-hospital mortality reduced by half in patients taking these supplements at the end of hospitalization and after hospitalization. So again, 50% reduction. Mortality number needed to treat was 20. So again, for a few dollars investment, you can save a lot of lives, we feel, and improve outcomes in a lot of patients. We think this is essential, one of the most cost-effective interventions we have. So as I close, why would an anesthesiologist and critical care doctor care so much about nutrition? And why do I hope you do too? Why am I so passionate and hope you are too? When I asked you how many of you have had surgery, and I said all of you will have 9.2 surgeries in your lifetime. So someday this will be you or someone you love. And for better or for worse, I've used up some of all of your surgical encounters, because when I was 15, this was me. This is me at age 15, who, much like Joshua, I had inflammatory bowel disease, was on TPN for a month. I've had 23 surgeries throughout my life. I ended up going to the OR emergently as a 15-year-old with a perforated colon, toxic megacolon, much like Joshua. Ended up in the ICU, and now I live almost on the edge of being short gut with an ostomy. And so this has been me, and this is where my passion comes from. Good nutrition saved my life. And unfortunately, this is still something I experience and prepare for every day. This was me probably in the best shape of my life with my son in July of 2014. Now, a few weeks later, I ate some quinoa. Don't ever eat quinoa. Got a bowel obstruction because I have adhesions. Ended up having to go return to the hospital I worked in as a patient. This was me in my own emergency room with a lactate of 10, a severe bowel obstruction, and marked bowel edema. I was rushed urgently to the OR, where the surgeons had to spend 8 hours releasing adhesions and clearing the obstruction. Because I was so sick, much like Joshua, I ended up in my own SICU with an open abdomen. This is actually pictures of my abdomen as it closed. And so, again, this were the things that happened that you have to be ready for as a surgical patient. I was hospitalized 23 days on parenteral nutrition with an ileus for 21 of them. And I went from looking like this in July to a few weeks later looking like this. I lost 20 kilos of weight in 17 days, and that was on TPN. So the ravages of what surgery can do are, no one is immune to these things. I wasn't able to walk down the block without being short of breath by the end of this period. I was running miles before this. And at the end of 5 months even, I was too weak to pick up my own child. He's much older now, but he was still someone I should have been able to pick up at this point. It took months to recover. So my nutrition optimization is a part of my everyday life. And what does it look like for preparation and recovery? What does that look like for me? Well, over 2 years, it took 4,000 calories and 2 grams per kilo per day of protein for me to recover from this operation. This is me with my ostomy on the beach in Hawaii. And I like to show this because I have many patients I counsel, in fact, some just yesterday, who feel like their lives are over when they have an ostomy. And I always tell them there's nothing you couldn't do before that you can't do now with an ostomy that you couldn't do before without one. And so I try to give them hope that they can still have whatever life they want to lead. But it takes work to get better. And I exercise. Again, it takes more than just eating right to recover. These are all the things I take to help me recover from surgery that I take every day. I take in a separate suitcase when I travel to take my supplements. And the ones in red there are things we're finding data for improving outcomes from COVID, perhaps. We're studying probiotics to reduce the risk of COVID, as well as vitamin D. We have some pretty good data and some pretty good hope in some randomized trials that we've begun that this can even help treat and prevent COVID disease. But how many of our patients will know what it takes to prepare and recover? Who's going to teach them? Well, that person is you. You're the ones listening that have this knowledge. And the key is surgical recovery begins long before surgery and continues long after hospital discharge, and we have to be better. So what are our key take-home points? Well, as Mike Rocott likes to say, surgery creates a teachable moment where people are willing to stop smoking, address their diabetes, lose weight, and change their nutrition habits, because it's the big marathon of their life and they know they have to train. This is a key moment. You can change people's habits forever. We have a duty to do that for our patients. And of course, it has to start with us. We have to show them a good example and care for ourselves like we want to have them care for themselves. Again, remember, many of your patients are malnourished and we're not screening for them now, and we can change their outcomes if we do. So we have a real opportunity here to do better for our patients, and we can do better. This is the simple 6 things. You got to screen, get your protein in, use your oral nutrition supplements, and use your dietitians. They will help you. This is our pathway for those who, again, want to see it. We use a high protein ONS, immunonutrition, and carb loads. We give it sometimes weeks before surgery, even to 7 to 10 days before surgery will benefit, and then we follow them for a month after we treat them as well. We've got some initial data from our RD-driven periop nutrition clinic here at Duke. This is data from 2018 to 2020, and we found improvements in length of stay index, ICU length of stay, mortality index, readmission, AFib, heart attacks, and AKIs, just from the presence of seeing a dietitian. This is before we started our major nutrition intervention study we're doing. So this was just them seeing a dietitian. We saw significant improvements for all of these just from an RD going over nutrition training with our patients, like surgery school. So again, we're analyzing further, but all provide strong signals for improvement following surgery just by the presence of a nutrition clinic and seeing a dietitian is the first 125 patients from Duke. So again, our average length of stay index change was almost a day just by the sheer presence of a dietitian. It pays for itself in a few months. We have a paper out that you might want to look up if you want to see how you can establish a perioperative nutrition clinic in your institution. This was just published about 2 months ago. It's free online. You can go to this website and get it. So now I want you to realize the way we feed and prepare patients for surgery should never be the same, and that no malnourished patient should ever have elective surgery without nutritional optimization. And I dream of a day when all of our surgery patients have the opportunity to be best prepared by getting their nutrition addressed. Because if we do, patients like Joshua might live to still be with us today. So as we finish, I want to let the people who do it best take us out. And thanks for listening.
Yep, that just happened.
What just happened?
Nothing.
Okay. Well then, next time I'll have surgery, I'm having it done ERAS style.
I'll have my skateboard ready. All right, back to work.
And with that, look forward. If you have any questions, feel free to reach out to me. You can reach out to my email that you saw at the beginning, paul.wishmeyer@duke.edu, or on any social media sites where I post many surgical nutrition updates. Thank you.
TopMedTalk. Thanks for downloading TopMedTalk. Don't forget to subscribe via your podcatcher. Don't forget to check us out on social media. We're on Twitter, Facebook, LinkedIn, and YouTube. And also, don't forget, TopMedTalk is the broadcasting arm of EBPOM, evidence-based perioperative medicine. We'd love you to find out more about that. If you check out ebpom.org, you can find low prices on some of the conferences we're organising around the world. Many of them are virtual and don't even involve you leaving your own home. Check out ebpom.org now.